A little introduction. Dr. Criss is a professor, as you heard, at Chatham University, and she's had a long career of, geriatrics. So today she's going to share a little bit of her wisdom, and we have two previous residents, Nanami and Sierra, to answer any questions you have about kind of the process and what it looks like to play that role of resident and what the, pros and cons of doing a residency are. So we can go ahead and get started. Thank you for coming.
Okay. Well, I'm really pleased to be asked. Kind of the connection came about because I am also the chair of the Residency and Fellowship Special Interest Group for the Academy of Geriatric Physical Therapy. So when I was contacted, this is something we love to do, is talk about residency, talk about geriatric specialization, and try to get people interested in working with older adults, because guess what? You're going to, whether you want to or not. So you might as well be really, really good at it, in our opinion. So I thought quickly, and I'm going to fly through some things, but I wanted to just talk a little bit about, first of all, I don't know in your respective programs they even talk about residency training. Some do, some don't. So quick raise of hands if people have even heard or have a good idea of what residency training is for PTs. Okay, so some hands, some right? Okay. So it's just a post-professional, meaning you have to be a graduate, you have to have your license, and it's planned. So it's a little different from getting a mentor when you go out in your first job. So there is a didactic and education portion. So you kind of are still in school, but you're also treating patients with your own caseload. And the mentoring is prescribed by the fact that we're accredited. So we're accredited through American Physical Therapy Association. And so you have to have 150 hours of mentoring during your residency program. And at least 100 of that has to be with your patients. So it's not you following someone around and them just kind of spouting knowledge at you. It's actually in the trenches. Here are your patients. What problems are you having? How can we help you? Kind of with your thought process, and how do we start applying all the literature that we might see, or lack of literature, as Nanami was saying earlier. Older adults, there is more and more research coming out, but there are many things that are still lacking in the literature. So the important part, and she can talk to this later because she did it very eloquently a few minutes ago, as we were kind of just acquainting ourselves and introducing ourselves to Carter. But that three-legged stool for evidence-based practice, it's not just what's in the literature, right? It's also your clinical experience and your patient's preferences. And that takes some experience. That takes a little bit of confidence when there isn't literature of how I apply something from something else and see if it works and is it safe. And so residency is all part of that process of trying to help hone your skills for that sort of thing. So I am fortunate enough to have worked with the other residency and fellowship special interest groups. So most of the academies at APTA, ortho, neuro, peds, cardiopulm, most of them have a residency and fellowship special interest group. And the Academy of Education with APTA has kind of brought us all together and has started a pretty concerted research effort to kind of say, does residency work? So I wanted to share with you just a little bit of the information that they've come out with. Can you see my screen? Okay, if I do that, can you see it or no? With my screen share? Okay, so one of the things to know is what we think, right, is that being a residency is kind of like bigger than just being a PT. It helps with faster development of your clinical competence. We believe the return on investments outweighs the cons and the barriers, we hope. And we're hoping it's starting to kind of change the culture of PT. So one of the things that's come out in the literature, and I will say that most of the literature is in ortho residencies because there's more of them. So they have a larger sample size, but some of this stuff has been done with any residency program that's willing to answer their surveys. But certainly there's been perceived higher clinical competence from residents themselves as well as their employers. Some differences in job duties that people see across the board after being residency and fellowship trained. Certainly more engagement as far as teaching and professional engagement and leadership, and we hope increased value. So one of the things that's come out of some of the research is they report a higher kind of reported perceived clinical competency. So these are residents kind of giving information about themselves, anywhere from a 3 to 9% increase in these things that the bullet points are here. So being comfortable with ambiguity. So versus people who are not residency and fellowship trained. So kind of those squishy things that are really hard to teach in a PT program as novices. So once you get out and you start having cases under your belt, we find that residents tend to be a little better at dealing with things that don't have black and white answers. They report being less overwhelmed by patient care responsibilities, have less difficulty prioritizing or organizing their patient care, which is important when you have a really busy day. So perhaps, and we don't know if that's significant, right? But there is an increase in what's reported from residency grads themselves. And the graduates themselves feel like the residency really improved their examination performance, their clinical reasoning, being able to treat efficiently, but particularly communicating with patients and communicating with other healthcare providers was one thing that we see residency and fellowship trained individuals kind of rate themselves much, much higher than people that are not residency trained. The other thing is employers' view of people that are residency and fellowship trained, anywhere from a 14 to 38% increase in perceived kind of clinical competence and professionalism type of issues. So employers feel that residency and fellowship trained individuals provide higher quality care. Certainly, some of them have higher work productivity, particularly in the outpatient realm again, because again, they're getting patients better faster. That's the one area where we've been able to show, because there are so many tests and measures in the ortho world where you could, your FADEs and your oswestries and things like that, where you can show that people are getting better that much faster. So it does seem that at least initial reports, and these are single studies, that there is kind of improvement in this clinical competence when you're residency trained. There's also some increase in teaching, mentorship, and research in people that are residency trained, with a drop, of course, because you can't be doing more research if you don't have a little bit of a drop in your clinical care time. So these are often people that are leading research studies, even if you're not in a university, but through like clinical research trials, and are kind of stepping up to think I think we should study this. A few other things, right? So we tend to see residents and fellows engage more in leadership roles. So, invited to speak nationally, getting accepted at CSM and other conferences, being on professional committees where they might need to be elected, having publications. So all these types of things, depending on where you were for residency and the residency type, anywhere from 2 to 14 times increase in kind of leadership roles post residency and fellowship. So this is busy, but I want to just point out that the yellow means that employers felt that residents and fellows substantially exceeded what they were seeing in people that were not residency trained. Okay, so a lot of yellow on this slide, just meaning that they felt like the kind of the things that managers look at, that residents and fellows perhaps do them a little bit better, including, application of evidence to practice in particular here. That's like the 4th or 5th down from the top, as well as providing quality care. So really important kind of outcomes that we hope lead to better patient outcomes, but these are obviously just things that are reported from managers. So why do people do residencies? When they've asked residents, so desire to provide better care is the first one, and the fast track to that expertise. So if you do a residency, you can sit for the specialist exam when you finish your residency. You don't have to perfectly count all the hours that you've spent. They just say you've done a residency, fine, you can sit for the exam. So it's kind of a fast track to that. And then things that are kind of anticipated or realized outcomes with residency training. So this was a comparison study. This was just a small study, but looked at what residents anticipated to get out of their training and then what they actually felt they got from their training. And a vast majority of things they felt were met. So in this study, as I said, a lot of this has been, there's just single studies. So we have some conflicting results, right? So previous studies had said that perhaps residents were more efficient. And in this one, for increased clinical efficiency, it wasn't necessarily realized. So again, we just are early research here. There's a potential for higher income. I will talk about that in a second because there's caveats with that I always like to say with students. But certainly perceived value is up. And for an organization, I know of several private practices that have marketed very strongly that all of their therapists are specialty trained. They all have their specialist certification. So for some smaller outpatient practices, that's a way for people to really set themselves apart from other practices. There is a chance that people make more money. What they're finding is it might not be more money, but they might reach those higher levels of making money faster, if that makes sense. I would always say that a lot of this just depends on where you are in the country. My students usually get pretty disappointed if we look at the APTA salary survey and they look like our area of the country and they look at a median salary and they think that's what they're going to make, and then they end up making less. And that really, and I'd say you have to remember Pittsburgh has a really low cost of living. And so that also means that salaries are lower. We're not going to make what they make in Boston. We're not going to make what they make in Philadelphia because our cost of living is lower. So you have to take any of the salary surveys with a grain of salt is my bottom line on that one. And it depends on if you're in a place that needs PTs. So Pittsburgh has numerous physical therapy programs, but post-COVID, there's a lot of openings, right? So it's all about market, okay, and kind of seeing where your value is. So there's actually also some evidence of higher career satisfaction for residency and fellowship trained individuals versus those that aren't. So 5% increase with residency trained and 9% increase with fellowship trained individuals. So maybe that's important, maybe it's not, I don't know. So there is a strong feeling, and Nanami had said this earlier, that being a resident kind of sets you up to be knowing what you don't know, and you need to constantly be looking. So it sets you up to be this lifelong learner. And hopefully it helps people be more satisfied and able to achieve their career goals. I think maybe also because we try to help you figure out what those are, and then you're better able to articulate them, perhaps. Once you're done with residency, there's that confidence of I can do this, and so then you can go for it. So some improvement in patient outcomes. Again, most of this is in outpatient orthopedic residents. It's a little easier to track improvement there. In inpatient environments, you don't always see the same person every day. So it's really tricky research, but there is some decent evidence out there that there's a significant change. This study was from a single hospital-based orthopedic residency, which is unusual. Most of them are outpatient based, and they definitely saw an improvement in their patient reported functional scores. So that's good news for us. And then fosters a culture of excellence. That's kind of what people are hoping for. But we want to certainly make people better clinicians and make them, motivated to become involved in their profession and keep that interest in residency going. So again, I not shamelessly, I was given permission, but I stole these slides from Matt Briggs, who did a lot of this research. This is the Residency and Fellowship Research Collaborative, which goes across multiple institutions that's been trying to get some information out. That's Matt Briggs. He's at Ohio State. If you ever get to meet him, he's a great guy. The other thing I wanted to point out, if you're a certified specialist, you are one of few. All right, so there's over 500,000 PTs in the United States, and only about 26,000 are certified specialists. So that's really something special. And these numbers are outdated. These are from the other year, but we're up to about 4,000 geriatrics certified specialists at this point in time. But boy, that's not a lot out of over 500,000 PTs. So knowing that our population is aging, we definitely need more people. The other thing I will say that the evidence is out there on pretty solidly across every specialty is that people that graduate from a residency pass the specialist exam at a higher rate, pretty much across the board. So what's circled here is the passing grades for residency graduates versus those that are not. And not that I did not go to a residency, right? I didn't even know they were around when I graduated. But there's some pretty good evidence that it does help prepare people to sit for that exam and to do so successfully, which is important because it's not cheap to sit for that exam. You don't want to be doing that on a whim. You want to make sure you're prepared. The last thing I wanted to point out to you all just is oftentimes when I talk to students, they say, I don't know, residency is competitive. I'm not sure if I would get in. And I just want to say right now, the red line here are the number of positions in residencies open. But let me go back. The orange line is the number of positions that were filled in 2021. We are not filling all our spots across the board, right? But in geriatrics as well. Okay, so there were in 2021, there were 29 residents across the country, and there were 38 openings. So if you're going to apply for residency, now's the time, right? Before things ramp back up. This is like the post-COVID nosedive here that we've had with applications, not only to PT school, colleges, but also residency. And so it's a good time to think about it because there are positions out there that you could get into. And the last thing I wanted to just share with you all before I let Nanami and Sierra take over, because it's probably more interesting to talk to them since they're actual residents. When we've asked our residency directors, what are you looking for in a resident? These are the type of things they come up with, right? So we want someone who has a commitment to geriatrics in particular. And you need to have demonstrated that somehow, right? So either your rotations, your clinical rotations in school, if you're not fortunate enough to have that be in the area that you're most interested in, then trying to show some interest in another way, right? Could you do some observations on a weekend when you're not in the clinic? Could you talk to area specialists, things like that? Are you volunteering perhaps in places? But really it's that commitment to being a lifelong learner. Residency is not about a lot of hand holding. You gotta manage your caseload. You gotta do your residency work. We want you to be forward thinking and be willing to say to us, I'm seeing this in the clinic and I don't like it, and I'm trying to figure out a way to make a solution, right? So we're looking for people with initiative, certainly strong organization and time management, and interested in leading, because residents, I think, end up being leaders. You're going to be looked to as an expert in your clinic, and so we want you to kind of have that fire to want to do that. So other than that, we've got a couple PTs here who have gone through a residency program, both Sierra and Nanami. Nanami is a GCS. Sierra's studying and getting ready for her exam. She graduated this past December, but we'd love to entertain any questions you have about geriatrics as a whole, and residency, if you have questions about that.
Hello. Oh,
Oh, go ahead.
Ever,
no.
don't fight.
All you, Dawson.
Okay. Well, thank you for your presentation.
You're welcome.
So my main question is, you mentioned the things that the directors are looking for and applicants for the residency program and getting exposure in our clinical sites. I guess I've never really seen specifically geriatrics in clinicals. So do you think you could elaborate and kind of advise how to achieve that?
Yeah, I mean, I think it's not hard knowing that our population older adult population is expanding kind of exponentially. I would say, you know, if you're going to a clinic that specifically says, you know, it does a lot of sports medicine, you'd have to say how many people were actually in the age group that you're interested in. But I think, you know, having an inpatient rotation and saying I was at a hospital, you know, a community hospital, and 85% of the patients I saw were older adults. I think that is perfectly adequate, right? So I think being able to talk about your experiences, we certainly ask. Most interviews nowadays are behavioral, so you know, asking about a specific patient. So make sure you have those specifics in mind. Yeah, so I think any setting you can see older adults, I would just kind of start either tallying or asking when you're out on clinic, do you know the percentage of people that are actually older adults that come here? Just so you have that in your mind.
Thank you.
You're welcome. There was somebody else that had a question. I'm trying to see where you are now on my grid.
I was just gonna ask for the residents kind of like how you kind of went about choosing that as your specialty, or what kind of cemented it for you that that's what you wanted to do.
So I can go first. So I always wanted to work with the older adult population. My first introduction to physical therapy was the older adult population. I started like volunteering and observing a physical therapist in an inpatient rehab setting. So that was just my input in the door. And then I also had like my grandma had Parkinson's, and I like, you know, she went through physical therapy herself. So that, you know, there was like some trend of like me wanting to work with like the older adult population. I feel like we talk about how we want to, you know, be able to age and like have a healthy lifestyle and everything as we grow older. And then like medicine is advancing, but at the same time, we're kind of, I hate to say it this way, but like neglecting like, you know, like different types of ways how we can improve quality of life for older adults. Like there's definitely still like ageism that exists within like healthcare like realm society itself. So I want to be able to like be part of that and like combat that part of like, you know, the society and just like healthcare. Like, and like I also like really like neuro, and we're working in a traumatic brain injury unit right now, in inpatient rehab. And a lot of people, like after I got my GCS and did my residency training in geriatrics, they're like, well, why are you going into brain injury? Like you probably won't see a lot of older adults, but actually I see quite a bit, unfortunately. Like I see a lot of falls. It like terrifies me more than than I was like a geriatric resident, how terrifying falls are, because like we are getting like patients coming in, actually a good amount. I would say like 80% of my caseload are older adults, like falls related. They hit their head, causes a brain bleed, or it could be a stroke, like following up with that. So like what's nice about the geriatric like residencies or like geriatric specialty is it's a population based. It's not just neuro, it's not just ortho like specific. You can have like this overarching education of like how to like be prepared to like care for our older adult population, but also you can go into like neuro geriatrics. You can go into like pelvic floor geriatrics if that's what you're interested in. Like there's so many avenue and niches like you can go within just like a population base. So like I can be very flexible wherever I go, and I can like still work with older adults. So that's kind of how I like thought my way through into the specialty.
For me in particular, I did work in outpatient and aquatics prior to entering residency. And my outpatient position was primarily sports. And so for me, just talking to prior to interviewing with residency, I did talk to the director, who at the time was Jen McMahon. And we just really just had a conversation. And what really struck a chord with me is that I personally never was excited to treat like the teenager like sports. I was always way more excited and got a lot more gratification from treating my older adults with MS or Parkinson's or just like fall disorders, things like that, than I ever got out of treating more of that sports ortho type of patient clientele. That, and then when I was going through grad school, I was actually living at home, and so I became extremely close with my grandparents. And so just kind of seeing that like the intergenerational kind of dynamics of my family kind of helped kind of bring me to my decision.
Thank you so much for sharing that, guys.
I definitely relate to a lot of what both of y'all just said about, how I personally see my future in hopefully geriatrics. I wanted to ask what the application process was like for y'all individually. How many programs did you apply to? That kind of thing.
So I personally was not, I guess, a non-traditional applicant in more ways than one. At the time that I was applying, I was already married and my husband's active duty military. So I personally never really thought, although I extremely wanted to do a residency, I knew that my chances were slim to none just because where we were really was dictated by his position and his job. And we move around so frequently, but we happenstance got Pittsburgh. And once I found out that there was residency programs out here through UPMC, this was the only residency program that I applied to because my husband was here.
I have a question. Oh, go ahead.
Okay, so from my experience, the application process was I was still in PT school. I'm trying to think back. It was December, so I would say like my second year. Sorry, I'm just going back to my
That's
thoughts.
probably right. Yeah, because they're usually due December
Like
timeframe.
second year, going into my final year for clinicals. So it was like that last semester before graduating PT school in my third year, was like the timeline for like applying and doing interviews. I applied to 2 programs and I chose based off of like teaching experience. I wanted to be able to teach, maybe like it didn't matter to see like if I wanted to like go into academia or not, but also have like a really structured, like well-known program. Like UPMC is what I ended up choosing and going towards. And just like the variety of the settings, like we have home health, we have outpatient, or and then we have inpatient rehab, acute care, ICU, and all these different things. And they're a long-standing program too. So those were some of the things that I was like looking for.
And I think it's really important just to research the program that you are actually applying to, because some of the programs or residency programs, they do focus more so on research, and some focus more so on that clinical aspect. And then some also have more of that teaching aspect mixed in as well. So trying to figure out like what you hope to get out of it and what your goals are for a residency program, I think is really important going into that interview. That way, you're setting yourself up for success within the program. Because if you don't like research and you picked a research heavy program, you probably aren't going to feel very fulfilled during that portion of it. So just kind of set yourself up for success within that realm too.
I always tell my students that, you know, if you want to apply to residency, I don't think the first time the residency director sees your name should be your application. We're really looking for people with initiative. And so emailing ahead of time and asking questions that show that you've looked at what they have available online. I don't know any program that wouldn't put you in touch with former residents so that you could talk to them and ask, you know, the nitty gritty questions like, oh my gosh, can you do this when you just got out of school and you have loans to pay? You know, all the things that people worry about, they'll tell you to a person it's doable. And I haven't met a resident yet who says it wasn't worth it. So, you know, you should be contacting them and asking your questions. There was a young lady in the pit shirt had a question. Is that?
Yes, I'm actually a high-risk student at Criss, but I live in Texas, so I'm really excited to hear that you're in Pittsburgh as well. We do have some of our geriatrics teachers, maybe you know them, but okay. Well, my two questions that I had, you already answered just after I say anything, but I wanted to ask, can you provide more information about how I was gonna ask about the type of rotations that you have to go through during the residency, and I know that may be different than the residency that you choose. But also about like your opportunities look like. Do you offer that, or how is that incorporated in the program?
I missed some of that because you froze. So you were asking about the rotations, but I missed the second part.
And how, whether your program offer a research and teaching opportunity for students, and how does that look like within like the normal day or week?
Okay, yeah. So just a few things. The accreditation program for geriatric residencies does require that you see acute care, skilled nursing, home health. I believe, I can't remember if there's another one. We have what's available to us a lot at the University of Pittsburgh Medical Center. So we do more than what's required there. So that's why you might see a difference across the spectrum. Our research component is not, with large research programs, we ask our residents to come up with a project or a personal kind of research improvement. So taking a piece of literature and trying to apply it to your own practice. And then we ask them to submit a poster to our state conference. It doesn't have to be accepted, but we want you to kind of go through the work and do that. And then teaching, we have some, not as much as other programs, and I'll let Nanami and Sierra talk about that. But there is a geriatrics course at the University of Pittsburgh, so not where I started the program, but then I moved on to teach at Chatham, and I'm still faculty, but we're all set up because of the University of Pittsburgh's relationship with the University of Pittsburgh Medical Center. So they do help with some teaching with the students that are in the DPT program at the University of Pittsburgh. So I'll let you guys talk a little bit about that. But your week generally is 75% of a full case, so of a 40-hour week. So they're in the clinic 30 hours a week. And the other 10 hours we consider residency time, which they can kind of talk about.
Thank you so much.
Yep.
So the teaching experience at Pitt DPT program, for our geriatric residency program, we connect with one of the geriatric professors at Pitt, and she also teaches not only geriatrics but also patient management 1. So your typical basic PT 101 classes. So we pretty much help with lab teaching. So we take small groups in each labs, and each instructor is kind of leading a group discussion, or it could be yeah, Vicky Horniak, yeah, that's her. So she has us lead small group discussions. And students are hands-on, and we provide clinical feedback and suggestions from there. And it really is dependent on how much comfort we want. If we want to just have a little bit of experience throughout the semester, we don't have to go every week. These classes are usually and labs are usually once a week. So it's really how much ever we want to. It's a lot of freedom. The geriatrics course is in the summer when I taught it. And then we would just be there as teaching assistants, adjunct faculty, just in the classroom with her during lectures. And then we would teach one lecture and lead a lecture there, and then help out with lab stuff. So, and then so our program is a 16 months program. So we have an opportunity to help out with multiple semesters, but that again, that's optional. We only have a little bit that we just have to have some experience in. And then we have, what's nice is an APTA clinical instructor level 1 course that we just all as the residents in all disciplines in our program gets to get a certification and to be able to mentor students as a clinical instructor. So that's another perk that you can have on to it, even though it's not directly teaching related for DPT programs.
And just to go off of that, our program does allow for some flexibility within the teaching realm. If you do have a strong interest in cardio pulm or neuro, you can also assist in those classes as well, as long as you reach out to those professors and talk to your mentor at the time to kind of fit it into your schedule and kind of shift things around. And then going back to more of that schedule, we're primarily in the clinic 30 hours a week, 10 hours of that time, or 10 additional hours, so 30 plus 10, 40, is more of that residency time. So that's when we're doing more of our grand rounds, which is an interdisciplinary, a residency partnership. So for example, me and one of our neuro residents, I did a presentation to all faculty and all other residents. And I believe it's actually on MedBridge now, or all of our grand rounds are on MedBridge for CEUs through Keelan, our head at UPMC for the residency programs. And so that is another thing that happens within residency as well, is that we do get to connect with all of the other disciplines of our residency. And I think that's what's so nice about UPMC is that we have that at our disposal and at our fingertips. In addition to what's included within those 10 hours is more of our specialty observation. So we go to an Alzheimer's clinic or a memory care facility, things like that, that are very important and kind of very directed towards the geriatric population. So just to kind of build our experience that not only within the population, but with the resources around us within Pittsburgh as well.
Our
really
residents also,
interesting.
yeah, sorry, I was just going to say the other thing is teaching isn't always to DPT students. So we also require in each of their rotations, their longer rotations, to do an in-service to the staff there. And it doesn't have to be PTs, if there's a need, and again, this is part of that initiative of looking at where you are and what the need is. And if the need is to educate nurses, then the teaching would be to nurses. There's also collaboration with physician and pharmacy fellows who are also geriatric specialists. And so there's a lot of teaching that goes in there. You know, there's been, you know, they've asked, can all the PTs teach them about assistive devices, right? Because they prescribe them, but they don't know really much about them, and they're not taught much about them. So sometimes there's teaching opportunities that way as well.
Thank you so much for sharing your experiences.
And I feel like all that teaching we did and like targeting different audiences, honestly, I feel like I've never done that much teaching and like in services in that short period of time, like ever. So like coming out of PT school too. So that like definitely gave me a good experience to like figure out like, okay, this is the topic or I'm gonna go over, who is my audience? And like I feel like I've been do a lot better after like getting a lot of that practice. And I feel like I feel more comfortable like presenting things to like physicians. And even though I was like really timid and like to be able to do that like prior to being a resident, I feel like I'm so much more confident and like I can build like really good rapport and trust with physicians. And it's nice when they like get to listen to like PT you know, advice and stuff from our perspective, from our field too.
Yeah, I had a question. I guess this would be maybe more directed to Dr. Criss because of her experience, but residents could take this too. Essentially, it's framed towards how can we better advocate for geriatrics as a specialty to just each other, but also like advocacy level. Like what are big barriers to practice that you face in your like day to day? I don't know if that's something that you've ever thought about, but.
I'd say some of the biggest barriers to practice are just flat out ageism in healthcare. It does exist. There are too many people who are told, you know, oh, you can't have that surgery because of your age. Or, you know, oh, of course you hurt, you're old. And I'll tell you, as someone who's in midlife, I don't like that answer. So I think there's a lot of advocacy to be done for that. I think the other barrier is people believe that, right? So your patients believe that, and they think, oh, I can't do that. And so we have a long way to go, I think, for being better at our people skills, not we spend so much time worrying about our manual skills and what actually being a PT is in when we train you, because that's what we have to do. But our words are way more important. And we talk about that a lot with like pain science now, but we got to talk about it as far as like convincing people that physical activity is the best medicine out there, period. Bottom. End of story. Right? If we could just get people to move more, and that takes some finesse, particularly if people are older and are fearful or have been told they can't do things. So I'd say that's a pretty big barrier. I don't know what you ladies think.
I think just as a society in general, and really big in clinic as well, it's just like the implicit bias that everyone kind of has internally, and just kind of advocating for self-reflection of the clinicians. Like once we do get out into the clinic, I think it's so easy to get caught up into meeting productivity and hitting the bottom line numbers. But like, are we truly listening to what our patients are saying to us, or are we just disregarding their aches and pains to them being older? Because not all the time are their aches and pains normal aging. And I think that's something that's so important to realize and to kind of self-reflect and make sure that we truly are listening and showing empathy to our patients in that regard. And I think one way to just kind of advocate for that is just calling people out. Like if you have someone that you're working with and you're like, hey, like let's listen to them. Like, I don't think this is just normal aging. This isn't. Like, physiologically, it shows that this isn't normal aging. Like, we have to listen to their aches and pains, and knowing that and having the background within that, and also having the evidence-based practice to support you behind that, I think is so important to kind of make that bottom line stick out high, like more prominently within the profession, I think is just very important.
Anything else to add there, Nanami?
I think you both covered it really well.
Okay.
I mean, like, I think we think of physical therapy and we like want to be like able to get our patients to get moving, and we know like we know, but they may not know too. So there's times like, especially like fear of falling cases. I have so many cases like that, like even now, and they're like our first like couple of days evals, second day for treatment. There's been times where like we take 40 minutes because someone's so fear of falling that like it takes 40 minutes to get someone out of bed. And that's really like hindering just like a lot of a lot of motivational interviewing I feel like I have had to do with older adults, and it's not a bad thing. Sometimes we just need to sit for 10 minutes to talk about like where their headspace is at, and then start educating and talking about movement and everything. Now, a lot of people like hate the word exercise, so let's not use exercise, use something else. Like those are some things like how we like project and like say things like because we believe it, like we might not be able to get the word across and everything. So yeah, it's a lot of talking to patients, a lot of like, cognitive behavioral therapy, motivational interviewing, a lot of that stuff needs to happen before we get them moving, like that physical therapy aspect too.
Yeah. I think the other barrier too is payment. I mean, it's really interesting to me, and yes, insurance, but it's also interesting to me that people will go pay privately for chiropractor or to go get a PRP injection, but you ask them to pay privately for therapy and they freak out, right? So we've got an image problem, right? We need to try to fix, and we have to be willing to realize that it's not all our realm. I mean, I think PT is really important, but at some point they have to fly and be free out of your clinic, and you need to be willing to refer them to a trainer or refer them to an exercise program, and so we need to start making those relationships and find ways that people can sustain what we've actually taught them to do. And that's for every patient. It's probably not specific to geriatrics, but I think even more so in older adults. Other questions?
Any last minute questions?
I have one last question. Do you think it's wise to wait maybe a couple of years, maybe 1 or 2 years after graduation to apply to a residency, or how is look in an application someone that just recently graduated and is now applying to the residency program?
From a director standpoint, I don't think better or worse for someone, right? If they're coming directly out of school or after a couple of years. I'm interested in the person, and everybody's journey is a little different. So we're more than willing to look at applicants no matter kind of where they're coming from. So I don't know. We were saying earlier, Sierra was out a little bit of time and Nanami went directly in. So I don't know if you guys feel that there was easier, harder. You don't know what the other person experienced, so it's hard to answer.
I feel like for me, it definitely was a little bit harder, being a little bit farther out of school, getting back into the rhythm of like that studying and the grind, of being just in school again, in quotations. So I mean, there is pros and cons, but honestly, like as long as you know what you want to do, if you know that right now, right out of school, like more power to you. Me personally, I needed a couple of years to kind of figure out where I wanted my specialty to lie. And I think that's okay too. Just make sure that you're confident in your decision, and that you took enough time and that you know what specialty you want to go into, and you're not making a rash decision just to say you did a residency. because ultimately it's you that's getting the benefit out of it. And if you're choosing something that you don't like, just for the sake of it, you may not get as much out of it at that point. So just making sure that you're confident within that specialty realm.
I would say if you're committed to do a residency, you know you want to do this specialty, I would go straight out of school. That's what I did. If you feel like you're hesitant, you're like, oh, I don't know if I want to do a residency. I'm not sure where I want to be in like year or so. I would say like talk to like any residency directors or any like residents that have like gone through residency programs in the past to kind of help you make your decision. But you don't want to just to apply to and then go through a residency program. If you don't like it, you don't want to just like up and leave either. So, and then another thing too, like pay isn't everything, but right out of school, like I didn't have a taste of a PT salary. I went straight to like, the pay cut of being a resident because of like the 75% case, like clinical, like time that I have, like the rest of the 25%, I'm doing a lot of more like the residency training and didactics course to prepare for the board exam. So I guess like that was nice to have like just go from PT school with like zero like salary to like a little bit of salary and then going straight to PT salary. But like I would say like that pay cut was definitely worth it. Like in return now, like all the experience that I have and the opportunities I've been given this up to this day, like even a short period of time, like after graduating residency. So yeah, I wouldn't say pay is everything, but that's like another con. I would say like that's a small con that I wanted to bring up too.
I think another way that at least my husband and I looked at the pay cut for those who like do decide, or for those that might decide to go back to residency after being out in the field for a little bit, we just personally thought of it as an investment within my career, and kind of putting that money back into kind of like me and like investing in that. And then knowing going forward, like I'm going to be giving my patients the best quality care possible, and I'm going to have a lot more fulfillment within my position knowing that. And I think that's kind of how my husband and I both looked at this decision and kind of with that pay cut.
Really helpful. Thank you so much.
All right.
Carter has my email, so I would just say if you guys have any questions, please feel free to reach out. You can also find my email on the residency and fellowship special interest group for APTA Geriatrics. So happy to answer questions anytime.
All right, we're coming up on the end of our meeting at 8 p.m. So I appreciate y'all for coming out to share your knowledge with Texas physical therapy students. I personally learned a lot. I think your presentation was very insightful, and especially to the residents for your practical knowledge of the space. It was very informative. So I appreciate you all coming out.
No problem. Thank you for having us.
Thank you.
Thank you. And I just wanted to say real quick, if anyone needs certification that they attended for their student portfolios, I have just sent my email again in the chat. So please feel free to email me. I am a USAHS student. I'm the president of the Geriatric Special Interest Group. So I can 100% do it for USA students. If you're from another campus or another school, still email me because I can still, most other schools have accepted my certifications. But thank y'all very much for coming to talk to us tonight. Y'all have a great night.
You guys too. Thank you so much.